to have an opportunity to do this today because you know about the food stories. And I've done a couple of grand rounds over the years, one on burnout, one on the history of this place, never one on my work here. So I want to share that with you. I'm not going to read this, you put on that little handout, but the thing on this is the three main publications that have come out of the Temp Perpetration Prevention Program are listed here at the bottom. And I will give you some more references later. But the public health approach, as you know, Dr. Kemp was very much about the public health approach to all of this. And because of him coming out of his work with smallpox, right? But I think that all of you are familiar with the idea that primary is the whole population, and secondary is at-risk population, tertiary is when you already have the problem. So everything in my program has had something to do with trying to reduce the risk of kids being abusive. So the general population of kids, what might stop any child from ever first committing an abusive act or a sexual offense. Specifically, that's the one kind of abusive behavior that kids actually wind up arrested and identified for. Secondary, what would be the risk factors, what would increase risk, and what to do about that. And then the treatment group that we ran here for 20 years, most of you weren't around in those days, but Jeff Messner and I ran a treatment group for 11 to 17-year-olds who had committed sex offenses. And we learned a lot from those boys about how they came to do that and what to do to get them to not continue to do it. Oh, wait. So my thinking about sexual abuse prevention, and really all abuse prevention, if you go back to Dr. Kemp in the beginning, is that primary prevention has to be preventing people from abusing kids. But with sexual abuse, when it came out of the closet, the early sexual abuse prevention work was all focused on victim prevention, to try to teach children to resist and report, to try to teach parents to be more vigilant and pay attention to who's keeping their kids, what's going on with them. I think victim prevention is secondary because nobody should be trying to be abusive, right? In today's world, there have been two major ways of thinking about perpetration prevention. There's a big program some of you may have heard of called Stop It Now. Came out of the Northeast. They've got chapters in a lot of states now. But Stop It Now approaches perpetration prevention from the adult side. Doing a lot of public service announcements and things, a lot of aiming at the general population of adults to increase awareness and get them to step up, be more vigilant, and confront situations where they think a child may not be safe and make those reports. And then they also put a lot of effort into messages directed at either active or potential perpetrators. So primarily adults, but they also have come over the years to address adolescents as well, with messages about if you are hurting a child, get help. If you're thinking of hurting a child, get help, right? Our approach here was to look at it from birth up. Say, what from birth would increase the risk, and what can we do to prevent that risk before children ever start being abusive? And so those are two, if you see on the lifespan, different approaches, but they're both perpetration prevention and victim prevention, right? So preventing abusive behavior in childhood and hopefully across the lifespan has been the goal, right? And I think with 30-some years of studying and using every possible source of information that might be relevant to this question, I think we have now really a well-grounded hypothesis about things that we can use to provide prevention and treatment strategies. You all are familiar with ACEs as adverse childhood experiences. And it was many years ago that James Garbarino had said risks accumulate. And some people, it's like building blocks. You put the fourth block on and it falls over. Other times you put the blocks on and it doesn't fall over. So that's really the resiliency piece. And throughout my work with specifically with adolescents who had sexually offended through the national networking and clinical work, we've arrived in today's world at risk reduction, health, promotion models, right? So really taking into account the protective factors and not just focusing on risk. So that's where the thinking around perpetration prevention takes us. It's not only what would increase the risk of kids ever becoming abusive, but also what would tip the balance against those risks. Right? Experience being the source of our worldview, we know that the risk of impacts from adverse experiences. In general, there's a whole category of things, and then specifically related to sexual victimization, there are some uniquely different potential impacts, right? But in experiencing any type of stress or adversity, human beings have defense mechanisms, which really are our advantage as human beings, that protect us from being overwhelmed, right? And defense mechanisms are something that have been talked about in all the psychological, psychiatric, developmental literature for years, because it's what separates us from the animals, right? That the basic instincts of fight, flight, and freeze, we have these cognitive defenses that kick in for us as human beings. And so they're really very wonderful advantages that keep us from being overwhelmed. So we don't either have a psychotic break or kill ourselves, right? But the risk with defenses is when they get overgeneralized. So the problem that creates the need for them never gets addressed, right? So never addressing the stressors, well, one of the defenses, or many of the defenses actually contribute to basically stuffing emotional things and not dealing with them. And we see then people wind up with this big load of emotional baggage that is weighing them down as they go through life. So one of the first, there's several basic concepts that form a foundation for these very simple strategies. One is the fact that there are patterns associated with behavior, what precedes and follows, right? And that actually what we refer to as a cycle is a very common human response to stress. That when we experience stress, whether it's a realistic stress in the present, a stressful day or a stressful event, or whether it's the stress brought on by things in the present bringing up that emotional baggage and being overwhelmed by past emotion, either way, our defenses come up to protect us, right? And it's in that defensive mode that we have that thought, what can I do to feel better or get back to self-control? And that's whatever thought comes to mind is what we think of as the fantasy solution, right? And whether that solution is a problem or not will be different for different people at different times. Right? It may be a problem or it may not. But if the fantasy solution actually turns into a plan, we can differentiate that fantasy from a plan by the plan taking on the reality of who, what, where, how could I actually do this thing. One of the things we learned from the kids we treated was that a lot of times their fantasy solution might be a perfectly normative thought of what might make them feel better or get back a sense of control, but it was the impediments to acting on that fantasy that shaped a plan that turned out to be doing something that posed a risk of harm to themselves or others, right? But whether or not it's abusive or functional, whether it's harmful or risky behavior or a perfectly functional solution, the only thing between the plan and the behavior is the decision to act when you have the opportunity, right? And the reason we're concerned about this cycle, recognizing how common it is, we all get into this pattern. It can reflect sometimes when you're driving on how you feel and how you react to that other driver that cuts you off. A lot of adults will get that reaction right away. But whether or not, even if it's a functional solution that doesn't cause any harm or pose a risk, it's still only a temporary solution if eventually you don't go back and address whatever that stress was. Either allow yourself to experience and process the emotion or deal with whatever caused the stress, right? Because you remain at risk if you haven't ever addressed the thing that caused the stress, right? So that's one of the concepts, that's the basic thing in the strategies that we use now. We know that the impacts of either acute or chronic exposure to those ACEs, right, can create overwhelming stress, right? And so then the danger is to get in the habit of this defensive posturing that gets habituated. So by overgeneralizing it, it becomes dysfunctional, and you wind up with many people arriving at either the helpless victim stance or the externalizing abusive stance. Right? And that's the connection that we see between victimization and perpetration. Research has shown that kids who have experienced these ACEs are at risk to be involved in many different types of behavior that potentially pose a risk of harm, either to themselves or others or property. And some of them become delinquent and commit sex offenses. Others go on to become abusive adults, right? So I think to address the risk of this, we have to first define what is abuse as a first step if we're ever going to prevent it from continuing. So realizing that it's not just sexual offending, it's actually the many other factors are greater risks to contribute to the risk of kids becoming abusive or being sexually abused. When we first started thinking about it, we figured sex offending, sexual victimization, learned behavior, right? But we learned over time that there's many different factors, and they're not all the same for any one kid. So the second concept that we came to use is that whether it's physical, sexual, verbal, or psychological, any behavior that poses a risk of harm to oneself or others or property can be defined as potentially abusive behaviors, right? And to stop the development and continuation of abusive behavior, we need to define, recognize, and intervene in all types of risk behavior, and then learn to recognize the patterns that precede and follow those behaviors, which reinforce the behavior and lead us to these habituated patterns of people who are pervasively abusive, right? So the abuse is abuse concept is actually very simple to teach, to use, to learn, right? That we simply say, anything that poses a risk of harm to self or others or property, and then we have some examples, right, under each, right? And it's the risk of harm, right? Risk of harm to self. You find many of those internalizing problems and behavioral disorders that used to get all be seen as separate problems, and now we see the connection between all of them. Abuse of others, not only individuals, but groups, so that widens the lens to look not just at interpersonal abuse, but also things like prejudice and discrimination against whole groups of people, and not just against people, but animals and pets as well. Right? So really any living thing. Abuse of property, obviously many times we would be much less concerned about abuse of property. And in using this concept with kids, we many times would hear, well, wouldn't you rather that I hit the wall than hit my peer? Well, your peer would prefer it, right? But I have to be concerned about the risk of harm to your hand and the wall, right? But I'm especially concerned if you're still using hitting as a way to deal with stuff. Many of you that have kids of your own or do any kind of work with kids will recognize that for generations now, parents and others have been told that if it's hitting, tell them to hit your pillow or the punching bag, right? We've known now for almost 20 years from the research on anger and aggression that acting out anger reinforces it. It doesn't actually have the cathartic effect that people expect it to, right? So that leads us to a strategy of teaching people not to teach kids to act out their anger, but to find non-harmful physical tension-reducing activities for kids when they're upset. Right? So that's an example of a very simple strategy relevant to this. But you see then examples of things that would pose a risk of harm to yourself or others or property, and then these three factors that we use to define abusive interactions: the lack of consent, the abuse of unequal power or authority, and then any form of coercion. And we, for years now, have been training people on how to define abusive interactions between kids. Because when you say consent, people say kids can't give consent. Well, they're talking about the legal construct of consent and not what consent in human interactions really means, right? When you look at the abuse of unequal power, right? Sometimes that's very apparent in age or size or role or positions, but sometimes it's not so obvious, right? It can be the unequal power of one can be stronger than the other. One can be very popular, the other not, right? And then coercion, you look at all the pressures that can be brought to bear on someone to get them to do something that they wouldn't otherwise do. We're pretty good at noticing overt coercion, like hitting someone or threatening to hit them. And we're even pretty good at picking up on trickery and bribery. But something like the threat of lost relationship or esteem, lost privileges, right, can be as big a threat to a child as something to cut with a knife. These are three things that we started teaching early childhood people back in the 80s. In the curriculum we had on understanding and responding to sexual behavior in children, right? That we can define what constitutes abusive interactions with kids, right? What's missing, thinking about, not just the bad things that happen to kids, but also the fact that in today's world, we know that actually, while sexual abuse is not the biggest risk factor, one of the biggest risk factors for kids to have all kinds of behavior problems is neglect, right? It's the absence of things, right? We see missing when we look back, clear back to the parents that lived in the Little House back in the 70s to the kids that we treated. The very common deficits that we see, one is acting out instead of using more effective communication, right? And people talk about that with little kids, that they show you with their behavior, things that they can't tell you with words, right? But we see that across the lifespan, acting instead of talking, right? And so that's one thing that's very common across all types of these abusive behaviors, right? The lack of empathic deterrence. So by that, we're talking about not just, sometimes it's the failure to notice cues in another person that would tell you that something you're doing is causing distress. Or sometimes it's noticing cues and misinterpreting them, right? And we know from research with kids that there's a lot of different things that contribute to them misinterpreting cues of other people, right? Or noticing the cues and knowing what they mean, but not caring that you're causing distress to another person. Those are three different failures of empathy that are very different when you're working with kids. Okay? Then the misattribution of responsibility that we see in abuse. The abusive father will say, well, you know, my dad beat me when I was a kid, but he beat me when I was bad. Yeah, I beat my son, but I only beat him when he's bad. What you see there is the attribution of responsibility for dad's behavior is to the badness of the boy, not to the decisions dad makes about his behavior. And we see that in the multi-generational transmission of this pattern, that externalizing, if you will, that's very common in abusive behavior. So those three deficits, when we recognize them, dovetail with the universal goals that we were teaching those early childhood people back in the 80s, originally thinking that these were the ways to respond to children's sexual behavior, but really realizing these three things address those three common deficits, right? To say, open up communication by labeling things with words. Put words to what you see or hear. Right? Foster empathy by not only recognizing cues and interpreting and validating the child's cues, but also by expressing our own emotions, right? A lot of times adults don't tell kids how we're feeling. We're really good at saying, I think you're feeling this way. But is it really the same as we're feeling all the time? And with abuse, one of the problems is assuming that other people feel the same as I do. Right? Well, I thought he liked it. He was scared to death. He was totally confused. So he didn't even want to be there. Right? And then that accurate attribution, whose behavior is it? And too often, the attribution of responsibility with children gets overshadowed by shame and guilt. And accountability is not about shame and guilt, it's about whose behavior is it. Right? Making that accurate attribution without attributing it to the person being bad. So with these three concepts, which run throughout all three areas of the work, the primary, secondary, and tertiary, that we see as very basic, relevant concepts for all the adults in kids' lives to be operating from. We've had curriculum now since 2002 where we're teaching not only the children's sexual behavior, how to understand and respond specifically to sexual behavior problems, but how to evaluate and respond to all kinds of abusive behavior, taking that tunnel vision off of sexual abuse and looking at all the ways kids can be abusive. Many times in early childhood settings, the kid's throwing the doll against the wall and nobody is saying a thing. But let the kid take the doll's clothes off and start looking at their body and people get worried, right? We need to pay attention to all the ways kids show us that they're learning to be abusive, right? Because imitation is reenactment of things kids see or experience is how children learn everything, right? And yet for many children, there's no one in their lives actually saying, this is what's happening, this is what it is, right? We heard when we started treating the boys in our group that for many of them and their parents, that somebody was concerned about their behavior prior to puberty. You know, sometimes very specifically concerned about sexual behavior. And, you know, somebody would say, well, he was throwing penises in kindergarten. Or he was, you know, grabbing the girls on the playground, whatever, right? And the kids would tell us, even when they got referred to therapy, and parents actually took them, all of which was not always the case, therapists didn't actually talk about the sexual behavior. Right? In traditional play therapy, you know, you're trying to create the opportunity for kids to talk to you, not to, right? But in today's world, we have very young children getting in really serious trouble for abusive behavior, especially abusive sexual behavior, right? So ever since I retired a long time ago in 2007, right, my goals for perpetration prevention here have been to disseminate the things that we have learned that have translated and eventually brought us to these really simple strategies that we can teach other people to teach other people, to try to disseminate information that might actually make a difference in how the adults in kids' lives interact with them, right? The other goal that I've had was to try to be sure that the things we've learned about perpetration prevention are integrated into the other things that are done at the center, right? And so to run very quickly through, as I said, we have these simple strategies that there's no reason to see that they would cause any harm to anyone, right? That's my test. When you have well-grounded hypotheses, but you don't yet have research that proves a certain thing does a certain thing, then I ask, would this hurt me or my children or my grandchildren, right? And is there actually a reason we think it might make a difference in the thing we're trying to prevent, right? So if there's no risk of harm, then thinking about where these strategies could be used. The trainer training that I've mentioned that I do, and then I also teach a class for clinicians who are treating kids, because that's really the tertiary prevention, right? But here at the center, integrating it here is not about getting every program to say it's doing some kind of perpetration prevention. I've said for years, everything we do here is perpetration prevention. If children were protected, if when they're abused, it was defined, like the child protection system does, saying this was abuse, right? If they had the treatment programs, all the things in all the programs here have something to do with reducing the risk of kids ultimately becoming abusive. If they don't, then we're missing an opportunity, right? And that's the thing, is that you can be conscious that you've got these hypotheses about things that increase the risk and simple strategies that might reduce those risks and moderate the effects of them, then just making sure we're not missing opportunities to not only protect children today, but protect the next generation as well, right? So that's my question for all of you here at KIP, whether you're doing treatment or research or teaching, to just think about whether you have, in fact, whether what you're doing does address in a congruent way some of the risk factors that we have come to recognize through the perpetration prevention program. And if not, if you can actually see that something is incongruent with with those things? Is there really a reason why it should be? And to think about things from that perspective, right? So going to primary prevention, right? The implications from the work that has come out of everything that I've done in my career, really, and perpetration prevention and the national network that I've had, we've been able to define a lot of potential risk factors and also to define protective factors in ways that we can show the relevance of those things to the development or continuation of behavior. I think it's really an opportunity in all the work going forward. People can know if something they're doing, that might be a plus on a proposal for funding, whether it's research or practice. It may be a plus if that proposal makes clear that you're not just concerned about the problem you're trying to address right now, but also its relevance to other things. Or you're not just collecting research on this one thing, but in the process, it also collects on this other variable that we have hypotheses may be related to perpetration. That making sense, right? So using the research that we do have, we have retrospective data from adolescents and adults, our own as well as lots of research out there on the overrepresentation of certain risk factors in the history of those who have been sexually offended. Years ago, Grant Steele had that kind of retrospective data on all the prisoners in Canyon City, because he was looking at the risk factors for becoming abusive parents and for criminal behavior, right? But knowing what some of the risk factors are, we know a lot about preventing risks in early life, right? We all know that there's things we can prevent if we know what needs to be done, right? So we can recognize and moderate risks, but the very best news is the primary prevention can actually prevent a lot. So we can go clear back to birth and start thinking about things that contribute to the prevention of kids being at risk to develop abusive behavior. The bottom line is that in my view, child abuse is very predictable and preventable. It's not a mystery at all. The bottom line for all of us working with kids who've been abused or at-risk groups is we want to help kids be successful. At the same time, we insist they not be abusive. We can't do that if we don't recognize and respond to abusive behavior as it's demonstrated in kids' behavior. So defining it, and then if we don't know what to do about it. But it's really very simple. Be successful and don't be abusive. So we can go back to birth. We all know good prenatal care is good for human beings, right? But we have research that shows that certain factors put infants at risk before they're even born. Right? So they're starting out at a disadvantage when they've been experienced drug and alcohol exposure, genetic vulnerabilities, premature birth. These are things that affect the condition and then the subsequent development of children. But an unwelcome pregnancy, they already knew that when I started at the center. That, many pregnancies are unplanned. Unwelcome and unplanned are two different things. Probably the majority of us in this room may not have been planned, but we were welcome when we arrived. Right? Very few. I have 3 children. Only one was conception actually carefully planned, so she would not be born in the middle of my first conference, right? It had to either be 8 weeks before or 8 weeks after. The other two kids, yes, I wanted them, they were welcome, but we didn't know exactly when it was going to happen. So, but good prenatal care can moderate or eliminate a lot of those risks that mean a baby's arriving in the world either healthy or with risk factors before they even arrive, right? Home visitation, you all know we have a lot of research on identifying at-risk moms, and with David Old's approach with nurse visitation, identifying risk factors, then addressing those through home visitation. We have a lot of research. Not all moms get it, but we know what to do, right? And in his research, he showed not only could he change the mother's life course and pay for it with decreased services, but that kids were more school ready, and then as adolescents, less delinquent, right? So that tells me that absolutely is part of perpetration prevention, right? Empathic care. When I started here, Dr. Steele always said it seemed to him the abusive parents had not experienced empathic care and then could not be empathic with their own kids, right? And that was what led Henry Kemp to that trickle-down theory. You got to reparent the parents if they're going to become able to parent, right? But what Brandt was referring to as empathic care, researchers subsequently defined as sensitive parenting. We now have a big body of research on sensitive parenting, and it's defined as providing care in response to the cues of the infant, right? So you can do parenting by the book. You can know what babies need, and you can feed them the right amount. You can even give them all the stimulation, meet all their physical needs. But if it's all provided according to the caregiver's agenda and not in response to the cues of the infants, it's not sensitive or empathic care. We have research on this. And what that research shows is that infants who are cared for in that way begin to respond to the cues of others around 18 months of life. Long before the kids have the abstract thought to have sympathy, the golden rule, to be able to imagine how someone else might feel based on how they feel. They can recognize the cues of others and know how to respond. That toddler who can come in a room and see someone crying and go and comfort them without crying themselves and with no knowledge of why they're crying, but because they recognize the cue of sadness and know how to respond. So it's obviously very relevant to the empathy failure that I mentioned earlier as one of those most common deficits. If you have never had anyone respond in a way that validated your own cues, that gave meaning to them, right, then the likelihood that you either won't notice or you will misinterpret or not care about the cues of others. And we saw this again and again and again as characteristic in the boys we treated, some of whom had never had empathic care themselves and didn't even recognize their own cues anymore. They were so defended and so out of touch with their own internal needs, right? And it takes a lot to correct that when it's not there. I think it can be done, especially when you get them young enough to hang on to them and work on it. But empathic care is definitely, and there's the research. So in parenting and education, right, are we just teaching parents what kids need? Are we just evaluating parental care based on, are we checking off all the boxes? Are we meeting all the things we know kids need to survive and to reach those developmental milestones? Is it actually being provided according to the cues of the child and not just according to an external agenda. It matters, it really matters, right? And I know from my own grandkids in the most recent generation who take new babies to their pediatricians, the pediatricians still tend to say, or their healthcare staff, whoever, those newborn visits, right? They'll come back, well, what did they tell you? Well, he should be eating 4 ounces every 4 hours, right? That's an example of what they do. Did they say how to know when he needs to be fed? So you have a parent who maybe didn't experience it themselves, trying to be a really good parent and waking the baby up to feed them for 4 hours. And then they don't eat well because they're tired. And then making the baby wait for an hour and a half because it's not time to eat yet, while the baby is crying and fussy and unhappy, right? So it matters, right? Consistency of care. We have a lot of research on the consistency of care issue, and it's all related to that attachment. We have tons of research on attachment. We know a lot about that, right? But that disruption of early caregiving relationships, it was the biggest risk factor in our big database we collected through the network of 1,600 cases of kids who had committed sex offenses. Parental loss was the biggest risk factor, 54%. For 12%, it was the death of a parent, but many other things that could lead to the disruption of a parental care relationship, right? We know that many times we have to disrupt relationships if the relationship is putting the child at risk. But every time we make that decision, we need to know we're creating a different risk, and we need to work immediately to try to moderate the effect of that disruption of care. And understand that kids that have had disruption after disruption. We see kids who've been treated like suitcases. They've gone from one place to another their whole life, right? It's no wonder that they're at risk, right? Well, so many times, though, it can be the adults' choices that we make about decisions. And many times, adult decisions about kids, where they're going to be, who they're going to be taken care of by. A lot of times those things are made more from the perspective of what will work for these parents or for this family or for this agency, right? And just always trying to look at it from the standpoint of favoring consistency of care. And that actually is so powerfully demonstrated in research in my field, the kids who are sexually offended, that's one of the guiding principles in the Colorado state standards for kids who commit sex offenses, that decisions should always favor consistency of care. Through the 0 to 3 and that organization and its publications and all the research, we now know just hang on. We have lots of research from the last 25 years about those early years of life, things that we know now about human beings that we did not know when most of you were born. Many in this room were not born before the time when they could do brain research on living people. In my lifetime, 30 years ago is not so long ago, but I have a sister and brother-in-law who did brain research, and I remember their excitement when the technology was there to actually watch a human brain. Because before that, all the research was done on cadavers, right? And you all know all the research on the brain and how much it's taught us about human beings and normal, healthy development, as well as the effects of trauma and all these other things. It's amazing what we know about human beings now. That I didn't know when I was parenting my big kids. I wish I had. But there's so much that's known now that doesn't get put into his lives. So we need to always look for those opportunities, right? But that all that developmental stuff, all the things that contribute to kids being successful, right? That's the protective factors, the competency. When we have kids, we would get kids at 14 that one of my colleagues referred to as developmental Swiss cheese. Right? Look like a 14, and it's amazing how well they pass themselves off as a 14-year-old. And yet a good developmental assessment would find they didn't have skills that a 4-year-old should have. And then people wondered why they were dysfunctional. So protective factors. We have all this research that the brain develops in use-dependent ways, and that's for better or for worse, right? And we know that the effects of unresponsive, neglectful, unsafe, or violent environments actually can be seen in physical and functional changes in the brain. So all these things, but we have a whole child protection system, we have child welfare systems, right? All these opportunities to be addressing all these risks, to either prevent or moderate these risks, if we recognize what really matters, like empathic care versus just feed the baby 4 ounces, right? Infant mental health and child psychiatry. I mean, a lot has happened there with not only recognizing the difference between this diagnoses that are really differences in the brain that are inherited predispositions as compared to things that are the product of life experience. Right? Differentiating those things and understanding that something that's a predisposition that is a difference in the structure of the brain, that's going to be a continuing factor for better or for worse in a person's life, right? But and some of you are probably aware of all the attention in child and adolescent psychiatry that has gone into trying to develop age-specific diagnostic criteria. You know, in the 80s, the denial that kids could be depressed because they don't look like adults when they're depressed. You know, their depression manifests with different symptoms, right? And the problem has been that we always try to figure out adults and then say, well, with kids it might be different, right? Why don't we study kids and then know that's how we can understand adults, right? But there's been a lot of progress in developing the age-specific diagnostic criteria, but it has a lot of promise for getting better, more accurate diagnosis and then subsequently better treatment. But when we talk about behavioral health, right, when we're referring to brain differences or mental or emotional health, I'm not sure about what we work against ourselves when we call all this stuff behavioral health. Because basically, behavioral health, if it's just bad behavior, not only do people look at it as bad behavior, right, but also they're much more likely to just get behavioral interventions, right? And we know you can do behavior mod and change a given behavior in a given setting, but my youngest daughter, who's 35 now, was in 5th grade when the teachers started saying, behavior mod doesn't work as well as it used to, right? Look around us at the world. The rules are not the same everywhere. When I was a kid, if I learned the rules at home, they were probably pretty much the same everywhere I went. My friend's house, school, church, down at the corner store, because we had a very homogeneous culture. In today's world, the rules are different everywhere kids go. They know it. They see evidence of that. So they push the limits. They test what are the rules here, right? And we spend all this time in struggles with kids around the rules. And a lot of times don't ever get to that emotional baggage or the developmental deficits, right? Because we just see the behavior as a symptom of bad kids not following the rules. And there are people treating kids who think all you got to do is teach them the rules, rewards and consequences. That's all you got to do. It doesn't generalize in today's world the way it used to. Right? Well, but we have this problem that the social stigma associated with mental health is still there. You know, this more recent trend to try to integrate child and adolescent mental health into pediatric primary care. I think that shows some promise, right? Because we have research that shows parents would rather talk to the pediatrician than go to the mental health center. But, you know, it'll be interesting to see how that evolves, right? But we really need to be careful about labeling kids as if their behavior defines them. Nowhere has that been more clear than with kids who commit sex offenses. Where labeling them sex offenders is absolutely counterproductive, right? Because then people think they're untreatable and they pose a risk to every other kid. And the reality is the base rate recidivism on juvenile sexual offending is very low for the majority. It's a very tiny minority that continue sexual offending after they've been caught, much less after they've been treated. So, all right, so you can't get rid of the window.
No, it's going to shut down in 2 minutes.
It's all right.
Sorry.
I can't. Really can't. Head injury, we all know the risks with head injury. Now in today's world with all the sports injuries, but you know, it was many years ago, back I think in the 70s and 80s, that Dorothy Otnell Lewis did research on all the juveniles on death row, where she just went like a detective to find every bit of information she could find from a kid's records anywhere, and found that if you got the records from the school and the pediatric and the mental health and all the child welfare, all these records that nobody had ever gotten all together in one place in dealing with this kid. But the head injury was a huge common denominator. That, you know, they had been in a car accident or they had fallen out of a tree, or right. And fortunately, we have a lot of effort going into preventing head injuries with kids now. But the relevance of head injury to abusive behavior, aggression, and emotional dysregulation, putting people in need of that defensive strategy to deal with emotional dysregulation and winding up posing harm. Okay. Cleaning up the pond, we have research on the powerful risks associated with deviant role modeling and witnessing violence. Witnessing violence is a much bigger risk factor for kids than being physically abused, right? Oh, now it's completely gone. Did I do that?
No,
children stood there.
Yeah, it was
Well, so you have it, yeah. I don't have it yet. I don't know what that thing's like.
Can I ask a question? Sure. We only have just a couple minutes left, but you were saying that, you know, one of your 2 goals was integration, and I just would be curious to hear where you see the program being integrated with, whether it's here, you know, other programs at camp, or, you know, where you see that going.
Where I see the integration? Well, I think I was saying earlier, if we use all the things that we've learned, and I'm not going to have time to go through all of these slides, but you've got them on the handout if you want them in a larger format or I could think to be said to you. But I think it's kind of self-explanatory, some of these things. But if you're looking at doing research on anything, if you're aware of the things, these really concrete hypotheses we have about the relationship between these things that I've just mentioned, right? From prenatal care through head injury, the exposure in the world and the pond, right? You are aware that you can show the relevance of those things not only to whatever you thought you were studying, but that those things may also be relevant to the risk of kids ultimately becoming abusive. It may be an advantage, right? And definitely the problem we've had in identifying and testing hypotheses is that a lot of these hypotheses, researchers treating adults have quit collecting the early childhood information because they have more recent variables that are more relevant in terms of their risk of recidivism. But we're talking about the risk of addiction, right? So I want to tell you, I have two things up here for these primary prevention things that I was just going through where I said we have research this. There's an article here that's called Preventing Violence and Trauma in the Next Generation. Very short, simple, but it has all the references for those things we just talked about, right? The references are in here if you think you want to have them handy. And also, it's a very succinct discussion of those risk factors, right? This paper, The Relevance of Early Life Experience to the Behavior of Sexually, this was written back in the 90s, and it has a more detailed explanation of a few of these things that I think are really critical. Like this is where it talks about that infant and empathic care and that research. So some of those things. So any of you that want to have the references, I think at some point you might have an interest in looking at how any of these things might fit or be incorporated into something you're doing, or how knowing their relevance, how it's relevant to it. I think that's where the relevance article explains better than I've been able to here in this format, the relevance of some of these things to abusive behavior. So I know we're out of time. I'm around.
Good question.
Yeah.
So you must have seen Colorado County agencies deal with a lot of these cases over the years. For those of us who are training county staff, county workers, supervisors, and whatnot, what should we be telling them? Is there something that they could change or improve about what we understand about these cases or what they do about these cases that we could help them improve practice?
Well, I think there's a lot, and some of what's relevant to this we already in what you teach, right? But maybe looking at whatever you teach repeatedly and thinking, is there anything in this that's actually incongruent with what I've been talking about? Taking the time, if you can take the time to read the relevance article, so you really have that understanding, you may realize that there's either something you're teaching that actually should be taught a little differently, or something you're researching that you didn't even realize was relevant. But that's my thinking about. It's not that perpetration prevention program is not going to continue here forever. I think we've learned what we need to know in order to not only to teach people preventive strategies, but also what we need to research on. And the research, as you know, prevention research, like David Olds, a prospective study to follow a huge number of children for years and years to look at these variables, it's not only enormously time-consuming, but it's also very expensive. I'm not going to do it, right? But we've arrived at these hypotheses by taking the pieces from a lot of different sources and where they intersect, it increases our confidence that they're actually making it. As long as they're not causing harm, right? So, I'm going to be around. You can email me. I know I can think something later. Thanks for the call.
Gail, for sharing your expertise with us. Well, these are coming with lots of food and make sure you fill out the evaluations. That's the foundation for the food. I know. Yeah. Yeah.
I should have said, Natalie is the one who's gone through my training. Currently, the only person at the center who actually knows a lot of this crap.
Need more of you kids too, right? Because I would try to work together.